Coagulopathy can be caused by congenital or acquired platelet or factor deficiencies. Acquired deficiencies include medications such as antiplatelets or anticoagulants. A common antiplatelet medication is aspirin, which is used to reduce cardiovascular disease and strokes. Aspirin exerts its effects primarily by interfering with the biosynthesis of cyclic prostanoids. Platelet function assays, such as thromboelastography, platelet mapping, and Verify Now, are tests that provide an analysis of platelet function and are used to determine if a patient has adequate platelet inhibition. Treatment for platelet-induced coagulopathy includes supportive care, as there is no reversal agent. P2Y12 inhibitors are a class of medication that prevents activation and aggregation of platelets. The medications within the class of P2Y12 inhibitors include clopidogrel, ticagrelor, prasugrel, and cangrelor, as shown in the chart depicted here. When anticipating invasive procedures or surgeries, P2Y12 inhibitors need to be held to minimize bleeding risks. The 2024 ACC/AHA guidelines recommend the management of antiplatelet therapy be determined by a multidisciplinary team to weigh the risks of bleeding, thrombosis, and consequences of delay of surgery. Similar to aspirin, platelet function assays can be utilized to assess for responsiveness or non-adherence to P2Y12 inhibitors. Additionally, platelet function testing may help determine timing of surgery following withdrawal of P2Y12 inhibitors, such as that for cardiac surgery. Similar to aspirin, supportive care with cessation of the medication and platelet transfusions may be necessary if a patient was on a P2Y12 inhibitor and is suffering from bleeding. Anticoagulants are varying classes of medication that are used to prevent or treat thromboses. Vitamin K antagonists work by inhibiting the enzyme vitamin K epoxide reductase and therefore prevent the synthesis of vitamin K dependent clotting factors, such as factors 2, 7, 9, and 10. International Normalized Ratio, or INR, is used to determine the effect of vitamin K antagonists, while an elevated INR level has been associated with bleeding. Prior to surgery or invasive procedures, vitamin K antagonists should be held for 5 days, and bridging with heparin may be considered in those patients deemed high risk of thromboses. For vitamin K antagonist-induced bleeding, treatment options include vitamin K supplementation, plasma administration, or prothrombic complex concentrates, or PCCs. Vitamin K reverses the effects of vitamin K antagonists, and the onset is approximately 2 hours if given intravenously. Plasma may also be considered as a way to replete clotting factors. PCCs include 3-factor, 4-factor, or activated PCCs. Guidelines do support the use of 4-factor PCCs over plasma in bleeding patients taking vitamin K antagonists. Direct oral anticoagulants are classified into 2 major categories based on mechanism of action: direct thrombin inhibitors and 10A inhibitors. Direct thrombin inhibitors include the oral agent dabigatran, while 10A inhibitors include the oral agents apixaban, rivaroxaban, and edoxaban. Global coagulation testing, such as prothrombin time and activated partial thromboplastin time, have not been proven to be beneficial in assessing the coagulant effect of DOACs. The one exception is using dilute thrombin time for dabigatran, where a normal thrombin time represents no residual dabigatran effect. Drug-specific calibrated anti-10 assays are regarded as the gold standard method for monitoring direct anti-10A inhibitors. If drug-specific anti-10A assays are not available, chromogenic anti-10A assays calibrated for unfractionated heparin can be utilized with sufficient accuracy. The 2024 ACC/AHA guidelines recommend the management of oral anticoagulants be determined by a multidisciplinary team with time-based interruption to balance the competing risks of thromboembolism and bleeding. Treatment options for patients on DOACs who are bleeding include plasma or PCCs similar to the reversal of vitamin K antagonists. However, direct reversal agents also exist for DOACs. For rivaroxaban and apixaban, andexanet alpha is a 10A decoy molecule that binds the medication, making it relatively inactive in a matter of minutes. Although andexanet alpha has been used in major bleeding with good results, the use in cardiac surgery should be carefully considered, as many case reports and series document the inability to appropriately heparinize for cardiopulmonary bypass. For the medication dabigatran, idrosubamab is an antibody fragment and directly reverses the effects of dabigatran within minutes.